Here at STAR, we have spent over a century on what has now been declared a national emergency, the mental health of children and adolescents. We are so proud to dedicate our 110th year to generate awareness and have conversations with community partners as we work together to solve this important issue. Today's session in our Mental Health Matters series is called The Physician's Perspective. This series, or this session in our series, is really going to help us understand the connection between trauma, toxic stress, physical stress, and mental health. We know that they are all so connected. I want to give a special thank you to our partner, Oaklawn, for their thought leadership, their financial support, and the excellent care that they provide for the greater Calhoun County community. Today's session will feature an interdisciplinary team of professionals from Oaklawn who will introduce themselves shortly. I'd also like to thank our studio audience joining us on our historic Albion, Michigan campus, as well as all of you joining us virtually. We are honored to have you here with us. And with that, I'm excited to kick off our very first panel discussion. I'm so honored to be joined by this powerful group of practitioners from Oaklawn. Can you please briefly introduce yourself, the important role you play at Oaklawn, and the reason why you said, yes, I'll come and participate in your panel?
My name is Chrissy Nault, and I'm a family and psychiatric mental health nurse practitioner, and I work in primary care, and I see a lot of mental health issues from adults to kids.
My name is Summer Liston-Crandall. I'm a family doc at Oaklawn, and I'm also our chief medical officer. And so I see this both from the perspective of being a provider in the office, as well as from an organizational impact that it has.
My name is Sherry Seifert. I'm a medical social worker for Oaklawn Medical Group, primarily in the primary care offices. And my role involves helping families and kiddos especially access behavioral health resources.
My name is Jake Lesak. I'm a social worker over at Oaklawn. I work in both the psych department and the emergency department. I work with all kinds of age range, various demographics. And I also work as a paid on-call firefighter for Athens Township Fire Department.
Excellent. We're so lucky to have you all here with us today. What I know is that the majority of children and adults who are actually first recognized to have some sort of mental health component, it happens when they are with their primary care physician, or it happens when they go into the emergency department. So this is just such a great group of people that will really help us understand what we need to know as we kind of work together and talk about how we can wrap our hands around this significant issue. So I'd like to kick off our questions with just, a topic that really kind of gets to the heart of the matter, and it's how is trauma or how is stress showing up for you, whether that be in your primary care setting or in the ED?
Well, I can speak in the emergency department. It's very common. A lot of people come in with suicidal ideation, increased depression, anxiety, and a lot of it's tied to stressors, financial stressors, things at work, feeling overwhelmed with, various responsibilities and things, and a lot of that, when I work with them, it's been building up for a long period of time that they've been under this stress. And so it's very common. I mean, even if that's not the primary thing that's going on, something happened and they're feeling this way, that's always in the background. That, if it's a financial difficulty, if it's work or whatever, that's a stress that they're constantly feeling.
Absolutely. So you're seeing some of these symptoms and reactions as a result of what they've been experiencing, but typically there's then a trigger that brings them in because things have been exacerbated so much. How else do you see trauma show up or stress show up?
From the primary care side, I feel like you see it in a number of ways, right? So people come in for a minor complaint and you try and treat it, but ultimately you realize, there's something bigger going on that we have to address. And even more recently, I'm seeing more and more kids and their families, and they're harder and harder to treat. Medications don't seem to work. So if you go back and you dial in on their history, it's a lot of trauma, and how do we kind of address that trauma? And has anybody ever addressed that trauma? Oh, nobody's ever worked with you on that? Okay.
So when you say minor complaint, could it be like a somatic complaint, a headache, a stomachache,
those are probably some of the more common ones. Or not feeling nervous at school, or unable to stay in school because their belly hurts. So a lot of that.
Yeah, and what we've learned over the years is just the significant connection between the way stress and trauma just gets into our bodies and our nervous systems, and then when it gets big enough and loud enough, it comes out in those symptoms and reactions. What are some other telltale signs that there's stress or trauma in the patients that you're serving?
Well, I think even at well child visits, when a parent mentions behavioral issues, the child is gaming too much, or having difficulties socially at school, or they're afraid they're being bullied, this just comes out in a routine visit. And so, that's a time for us to explore that a little bit more. I mean, recently during a well child visit, a kiddo was complaining of stomach pain and was talking to me about how stressful it was to do the visitations. Parents were separated.
Oh, right.
And what that brought out. And she said, we talked about, had things ever been physical between the parents? And yes, there had been lots of arguing, but she remembered one incident in particular that she was having nightmares about, and that was when it became highly physical between the parents. And I said, what were you thinking? And she said, I thought he was going to kill Mom. And I think we know that we can't assess trauma situations without knowing what was going on in the child's mind. So she thought her mother was going to die. That just takes it to a whole new level.
Absolutely.
Right.
Right. And it's not just the argument in front of her, but this belief or this worry of an impending fear of losing that parent. Oh gosh, so it's really, really manifesting in ways that if we focused on just the headache or the stomach ache or the behavior or the too much gaming, we could miss what's underneath, right? And you allude to the fact that you're like, okay, I'm kind of assessing and trying to figure out everything that's going on, and this is just at a well child visit, right? So speaking to, and we'll talk a little bit about just this need to be so curious when we're trying to be trauma informed, or look beneath all of the symptoms and the reactions that we're seeing. What about you, Dr. Liston?
Yeah, so as a family doctor, I see patients of all ages. And so not only do I see the children and teens, but then I see the adults. And I can see the impact of trauma at all of those ages. In an adult who has chest pain, difficulty breathing, headaches, some of the things that Chrissy mentioned, or they might be telling me they're anxious and that they're struggling with substance abuse. But if we don't dig underneath and see what was underpinning all of that, we may miss a big portion.
A big portion of this, yeah.
And patients that I've seen for years suddenly tell me about their traumatic experiences as a child and teen. They might say, have I ever told you about being abused as a child? No, but thank you for sharing, and let's talk about that.
Absolutely. And then just how helpful it can be to connect that dot for the patient, that like, wow, this is something you experienced that is now showing up in these ways in your life. There's nothing wrong with you. You're not bad, but this is manifesting in your body in ways that are coming to life now. Could be much, much later. So yeah, it's just so clear, the somatic complaints, the physical symptoms and reactions, the behaviors, the trouble with school. And what strikes me is that when I started doing this work, we only talked to mental health practitioners about trauma and stress, as if they were the only ones that needed to really know about it. And now what we're learning is it needs to be an integrated approach and all hands on deck. Absolutely. So, we talk a little bit about this idea that stress and trauma kind of embeds itself in our body, right? And it activates our nervous system in a way that we might be able to kind of handle for a short time. But after we've felt that way for, too long, our bodies start to say, like, stop, help me, right? And that's how those symptoms and those reactions come out. And I wonder, did you learn about that connection when you had your training as a nurse practitioner or as a physician or a social worker? Just this connection, because I think so many of us think mental health practitioner. Right, let's connect them to a counselor, a psychologist, a therapist, a social worker. And so much of what we know now is that the manifestation of trauma and stress is in the body, and it comes out looking like a mental health problem, right, when maybe it's just the dysregulation of that physiology. So it's like, when was the time that you learned? Was that part of your training?
I can speak as a social worker. When I was going to school for my master's degree in 2016, 2017, and it seemed to me at that time, I'd be curious to hear other people's experiences, but that we were just starting to head down that path a little bit, that there was, and still in some ways is, just in a lot of people's mindsets, this separation, like you were saying, of mental and physical health. We're all one being. Our brain is part of our body. So.
And it's interesting because you were in a social work program,
right?
So they're hinting at that to you. What about you in your training?
I don't think we've ever talked about this when you and I have, had our own chat. But I graduated with my family nurse practitioner in 2012, and I can honestly say it really wasn't. It was very much, okay, we're focusing on family practice and doing primary care complaints. But through my tenure of working as a family nurse practitioner, realizing there's so much more to this, that I decided to go back for my postmaster's in psych to become a psychiatric nurse practitioner, because really, even if I can get somebody into a mental health professional aside from myself or do integrated care, there's just not enough. And so much of what I see could be benefited by that.
Yeah, right. So it wasn't until you were in a specific psychiatric program that you were able to, learn and get some information specific.
Yep.
Wow. Yeah.
And I would say, so I finished my training, medical school in 2004 and family medicine residency in 2007. And then family medicine does, support a biopsychosocial model. And by that I mean, the impact of biology, psychology, and the social networks that people live in. But I don't remember hearing the term trauma. Yes, we talked about PTSD. That was perhaps the one time that the word trauma was used.
Sure.
But it was thought to be a limited condition.
Like that one exposure.
Right. Or somebody who had, who was a veteran. I expected trauma to impact their life. But I only think now that we're starting to say the word trauma and resilience, and it's growing in importance and growing in recognition.
Yeah. Do you have anything to add?
Well, I'm not going to give you the dates of my training, to tell you that much. But I did do my training at U of M, and I worked at U of M Hospital. And really the cases that we saw, I started seeing a lot I was in the neurology clinic, and people would come in with a paralysis on one side, and there'd be no physiological reason for them to be paralyzed. But then when I would talk with them, patients, I would say, well, at least tell me what's gone on in your life in the last 6 months. And they would say, my husband killed himself. So a lot of those cases we would just send immediately off to psychiatry. We didn't really talk about trauma as sort of a concept. I think back then we were a little more focused on grief and loss and how that could be carried into your physical state, unresolved grief, but not so much trauma. But with each case, whenever a case came in like that, unexplained severe fatigue, we've ruled out depression. Almost always when I would take a history, there would be something traumatic that had happened within the last year, even, not even going back further than that. So,
wow. Yeah, and the work that we do across all disciplines, so I know today we're really focusing on healthcare. What we're learning over and over again is that all of these child caring or human caring professionals are trained to do what they're trained to do. You're trained to do your differential diagnosis, and you're trained to say, oh, there's a stomach ache, there's a headache, there's partial paralysis. What are the underlying causes from a physical perspective? Just like all of our educators went to school to teach kids how to learn, right? And what we're finding is that because everything is so connected and people are coming into the field without the awareness that they're doing the best that they can, right? With the information that they, like Chrissy, you said you didn't hear about trauma or stress until you went into that psychiatric portion of your training. So what we're really learning is that this is something that needs to be a foundation for anyone who's working with people, right? And what we know too about this mental health crisis is that part of the problem is there are just simply not enough mental health practitioners to meet the demands of all of the things that children and adolescents and their parents are struggling with. So, I think it's interesting to begin thinking about, and maybe from your perspective, you have a job to do, but you also know that this is a huge piece of the puzzle. And now we know that this is a crisis, so it's all hands on deck. So how do you integrate that curiosity and what you now know about the impact of stress and trauma just into your interactions with your patients and still kind of get your job done? It's got to be so hard.
I can speak for myself, and I know that I find myself asking a lot of questions, and I'll preface it as...
There's the curiosity.
Yeah, the curiosity piece. Like, I'm not asking it to be rude. I'm not trying to be, hurtful. I just really want to understand, and I don't want to assume that I know something.
That's so perfect. Because, one of the key tenets of what we think being trauma-informed is not to assume. So just because that stomach ache came in or that partial paralysis came in, don't assume that we know what's impacting it or what's beneath that.
We're really exploring what trauma is, because you kind of brought that up, doctor, that sometimes people see trauma as one thing, especially it's veterans experience trauma that way, police officers, first responders, whatever, but we don't necessarily look at what the big picture of trauma is. There's a lot more to it than just that. So kind of having this discussion with our patients, like, hey, here's what trauma can look like. Here's what trauma can look like, when you were a child. Here's what it can look like now that you're an adult. One thing I don't hear a lot about that doesn't get brought up a lot is food insecurity. That's traumatic.
Just
that's a huge thing that's going on right now. Food's getting more and more expensive. Mm-hmm. And that's just one example that I don't think a lot of people would say, hey, that's trauma, right offhand. Mm-hmm. And so I think kind of defining, hey, here's what trauma looks like when we're doing assessments with our patients, because a lot of times I think the trauma they don't think about it.
I love that. So you're doing a little bit of education, even with your patient, to connect those dots, to say your experience of food insecurity causes a stress response in your body, and that often manifests in symptoms or reactions. And I think that's a key concept for so many people to know, anybody who interacts with another person, that trauma isn't just an event, like you said, Dr. Liston, it's not just PTSD, it's not just for veterans, it's the ongoing experience of having exposures to stressors or to something you have no control of. And one thing that stuck out in my mind that you said is it could have happened yesterday, or it could have happened a long time ago, and it can still be impacting us in the here and now. And we talk about that when we talk about intergenerational trauma and racism as trauma. So, so that's a great way that just in your interactions, you're being very curious, you're doing some education with your patients. What else can you do to kind of build that piece in and still get your assessment done?
In some ways, just reframing it, because the word trauma seems to have a capital T.
Yes. Lower T, right?
Right, either lowercase t or just using the word stress. Yeah. Like, as a child, did you have times where you were, under stress often? And you can give some examples. And I like that food insecurity and separation from a parent and things like this. I mean, these are things that people might not recognize as having impact in their day-to-day still.
Yeah.
But so using the word stress, and then you could reframe it as that that is a traumatic experience.
Absolutely. Mm-hmm. So trauma isn't just trauma. Prolonged stress is trauma, right? And that is something that is kind of like this, whoa, because a lot of patients probably think well, I don't know, nothing's really happened, but it's just that's how their life has been,
right?
Year after year after year.
Yeah, there are plenty of times that Chrissy and I'll collaborate on patients and we'll speak of just the discord and the disorganization of their life. Like so many things have been just off kilter for this child, this teen, this adult, that has led them to their anxiety experience or their heart palpitations or, to some of the stronger, paralysis like you described, that it's, I would like to lift those people from their chaos.
And see what happens.
Yeah.
See what happens to their blood pressure,
right.
And see what happens to their, belly aches and their
right.
headaches and their muscle tension. Oh, wow.
And certainly, letting people know. I mean, we all experience traumas on some level, but you're not a victim of trauma. You know what I mean? This is something that you've experienced. I know I was at a trauma workshop where someone gave an example of they had adopted a child and they went home with all that knowledge about, you've experienced trauma. And the kid said, great, you're going to put another label on me. Now I'm the kid that was adopted, right. The kid whose mother's in prison, and I'm a victim of trauma. So right. Not to normalize it, but, to help give a framework for the suffering you're going through or the challenges that you're facing.
Yeah, and that's why I love what you said, Dr. Liston, about using that word stress, because we all can relate to that, and it makes us feel normalized. Like, oh, we all have stress, and when we have stress for a long time, it causes changes in our body, right? And I just want to talk about too, just like this collective trauma that we've experienced over the past several years since the pandemic, and with all of the racial tensions and the political tensions, and just how that has just sort of come down on our communities and our children and our families. I know we're addressing a mental health crisis in childhood, but we know that the adults that are caring for those children are also significantly stressed. And those same adults are physicians and they're nurses and they're teachers, and they are trying to be all of these things. So how are you seeing that show up in your system? Are you seeing that in the adults and the children, in your professionals and your patients?
There's certainly been a rise in adolescents and young adults who I've had come into the unit with suicidal ideation or increased anxiety, especially in the last few years. And I think the big thing about a lot of the political things that have been going on, as well as the pandemic, is, especially when they're at a certain age, it's just difficult for them to wrap their head around all that.
Yeah.
You know what I'm saying? To understand, how to feel about these things, and I think parents, can do an excellent job trying to explain, what's going on and, discuss it with them, but I just think they're big topics for kids to wrap their heads around, and I'm seeing that kind of manifest itself as higher anxiety.
Yes.
So
the anxiety, right? It's like I have this visual of stress and trauma just coming up from the feet.
Yeah, absolutely.
And it's like the anxiety, and then the behavior, and then the substance abuse, and the at-risk stuff.
And then it peaks out in crisis situations.
Yes.
Where we see
in the ED.
People in the emergency
in the
department,
ED.
for sure.
Yeah.
I think one of the unique things about working in primary care and working in family medicine, so seeing adults, seeing their kids, seeing grandkids, is that you realize, yes, stuff comes up in well childs, but even then you can kind of almost get a read on the parent, and you're like,
Yeah.
oh, they've got something that's going on that never was addressed. And for people who weren't raised where we talked about trauma or stress, or they couldn't deal with it because their parents didn't believe in depression or anxiety, you kind of pick up on all that, and you're like, oh, this is why this kid is struggling, so now I got to get help to this parent.
Yeah.
And kind of parenting in general is tough, and parenting through a pandemic, nobody's ever done that before. So just resources, and you see it kind of bubble in every layer.
Validating the experience of the stress. Like, anybody would be stressed if this was happening. So, to take away, we don't want to victimize you or label you as trauma now. We want to say, oh my gosh, look at all you've experienced, and how can we best support you given all that has happened or continues to happen.
I always try and normalize doing family sessions with people. A lot of times people get this idea, if we're going to do a family session or couples therapy or whatever,
things are on the rocks. Things are really, sometimes it's just a good idea to discuss things, and I was, thinking about that with what you said there, that sometimes just having those discussions, like, hey, even if you don't think something's going wrong, let's talk.
And the education that you said you provide, I think is so helpful to just have that awareness.
Yeah, I was going to add to what Chrissy said, that the multi-generational aspect of the care we provide is really remarkable. And so we have a family that we take care of that we've seen for more than 10 years. And as a teen, this was a girl who was passing out at school or having convulsions, and none of that had any explanation that we could come to on a sort of biologic model. In the years since, she's become a mom, and her daughter now has complaints that include like vomiting and poor weight gain and abdominal pain as a toddler.
Wow.
But across the course of our time, we've also taken care of the grandmother and even the great-grandmother. And you can see these patterns of how the parenting experience across these generations has been a very disruptive and kind of chaotic life.
So do you think those symptoms and reactions across the generations are because of attachment?
I don't know if it's attachment or if it's just
anxiety.
If it's just that each of those generations has been raised among chronic stressors and trauma, and that's reflected then in a lot of somatic complaints. And further highlighted by a pandemic where seeking care has been difficult, and this family, she actually works in a medical facility, and so the young woman, has had to leave her daughter and has been ill with COVID a number of times because she works in medical care. So.
Wow. It just goes on and on.
It does.
So, we talk a lot about stress, a lot about trauma, and, I always try to bring it back to this place of, okay, if there's nothing we can do to control what happened, and there sometimes isn't anything we can do to control what is going to continue to happen, let's say in this intergenerational, the way parenting has been passed down from generation to generation, and the anxiety or the chaos that's involved in that. How do we as professionals say we're still going to have hope that there's something we can do, right? Because we have control over what we see in our exam rooms, over what we see in the emergency department, and we can do some education and we can normalize. How can we provide this sense of, not just to our patients but to ourselves, this hope that we can do something, right? And I think about the word resilience, and I'm just wondering how you try to infuse that in your conversations or your care, knowing that in many instances the stories are really difficult, as you've mentioned.
One of the big things that I think can help with that, and I'm really encouraged with the direction that we're heading, both as a profession and as a society. We have a lot of work to do, but is reducing stigma. And I think that's a huge part of this, is that, people do go through things. People get diagnoses. People get, go through traumatic events, difficult events, and, being able to talk about it openly and without, shame. I think that's a big step. That's not always going to fix problems that are going to happen in the future, but it can at least help us have open and honest conversations about that.
So you're giving them some words to help them describe what's happening and let them know not to be ashamed of it.
Yeah, and we have a ways to go, but I do feel that, conversations are starting to happen more frequently that I think, 10, 15 years ago just weren't being talked about. And I think that is one thing that is kind of helping us head in that direction.
Sure.
So I think one of the other things that I've noticed, and I've worked with Sherry a ton, is getting people resources. I feel like people don't even know what's available to them or how to access them. Or I had a family that I was caring for, and the mom has been caring for children that have had mental health issues for a long, long time. And mom came to see me as a bridge till she could get in to see the normal psychiatrist that her daughter would see. And she said, I didn't even know of all of these resources.
Wow.
I had no idea that all of this existed.
Yeah.
And so it feels like there's just not an understanding of what's available, and kind of disseminating that, like, oh yeah, let me get you some resources. Let me show you what other options there are. It doesn't just have to be this one thing.
Yeah.
And their partnership with community mental health.
Yes.
And having a teen who his peers reported to a teacher that he was suicidal, that he was expressing that. And by the time I saw him, it was several weeks out. We arranged some counseling, but he pulled out of his back pocket his safety plan.
Oh. And that was from school.
It was a really great collaboration between school and Summit Point being on the ground at the school with one phone call.
So what I'm hearing in this is you're curious enough to kind of be aware that there's something up and you're connecting, right? You're connecting with these families or the kids in a way that is allowing them to share. And be receptive to your education, be receptive to your support, right? Be receptive to like the offering of resources. How do you connect, right? We know that feeling connected and a sense of belonging is just such a great protective factor, whether you're in a school setting, in a family, in a community, a church. And, similarly, when you come into a well visit or you come into the emergency department, how are you building that connection, that sense of connection with your patients?
I would say I try and just meet the patient where they're at. I'm not here to judge anyone with what's happening, especially in crisis situations, like emergency situations. I've met with many patients who are just embarrassed to tell me what's going on.
So what's something that you say to kind of like lower their worry or lower their anxiety? Like
I'll tell them pretty directly, like, there's nothing here to be ashamed of. You're here to get help. If I need you, sometimes I'll
right.
You'd never be embarrassed to go to the emergency room because you broke your arm. You know what I mean? Maybe depending on what the situation is that caused you to break your arm, I guess, but you wouldn't be ashamed of that. You shouldn't be ashamed to come here because you're struggling with substance use, you're struggling with mental health. I see it so often where, I'll have a patient who will come up positive for every substance in the book, and they'll tell me they don't use because they're ashamed to share that. I'm not going to get them in any trouble. We're an emergency department. This isn't law enforcement. Let's talk honestly about this and have that conversation that, listen, we're here to get you help. Let's talk about what's really going on.
I like
that kind of thing. So.
And I was just going to speak to building that trusting relationship in all aspects of care. So, I'll do certain things where I make a note of where, what child likes what. So I might make a note of, loves gymnastics or enjoys Frozen, as a conversation we were having just a moment ago. Yeah. And that's something that then I'll draw upon, and you can actually sometimes see it in my notes, that I will then sort of paste it into my next note and bring that back up.
Great.
Like, so how's gymnastics going? Oh, you've moved on to something else. Oh, let's talk about that.
So you're getting to know them.
Right, I do that with adults a lot. Oh, where's your daughter in school now? Oh, that's fantastic. And truly copy paste. I mean, it's a wonderful thing to be able to then make these people feel like whole people. They're not just there to have a stomach ache or to have their annual exam done, but they're there because they're a whole person and they're experiencing a whole person's range of experiences, and just make them feel like I care.
And what happens, when you say like you have nothing to be ashamed of, or you ask a question related to somebody's interests, what can you see happening in their body? When you say things like that, or you ask questions?
Yeah, they start opening up a little bit.
They relax.
Yeah.
Just kind of.
And I think something even as simple as just like, hey, I like that shirt you're wearing there. Cool, I like that band. Something like that, just to break the ice just a little bit can help. That I see you as a person. You're not just patient number 8 for me or whatever like that. And whatever you're going through right now, it's okay. Right. We're gonna work on that. That's why you're here. I say that frequently to my patients who are in there, especially when I shouldn't have came. I don't know if I'm really suicidal. I hear that a lot. I'm really glad that you came here because these thoughts are an emergency situation, and you did the appropriate thing coming into the emergency department. So, that's another thing.
I think a big piece of this, and maybe a big piece of wrapping our hands around this issue, is the whole idea that being trauma-informed or providing trauma-informed care or fostering resilience isn't just something the mental health practitioner needs to do. Just these simple things that you do, these sort of strategies that, you're saying, I just, connect the last year's visit to this year's visit, that is being trauma-informed, and it's being curious, and it's getting to the root of how this mental health is showing up. And I think that provides me with some hope too, that there is something we can do. It's not this big, huge thing that we can't control. It's like, okay, every time we go into the exam room or every time we try to connect with a patient, we have an opportunity to provide them with this new experience that says, this guy's not ashamed or not, doesn't think there's anything wrong with me that I do this. He's like, okay, I'm glad you're here. And, Dr. Liston, wow, she's Dr. Liston. She really remembers that I love the movie Frozen. Those things are so powerful. And I think when we're able to share that information with educators or probation officers or, physicians, that that's what being trauma-informed is, and that's how we can do our part in this crisis. It makes us feel pretty good about the fact that there's something that we can do.
And when you spoke, so Dr. Soma spoke with our medical staff about 3 or 4 weeks ago, and just highlighting that there's small, sort of easy things to show a community with, that you are in a communal experience with these patients, and that you are a resource to them, and that you can, as providers, help provide a holistic approach to their concerns. So
yeah. Any other last minute strategies or things that you're doing that's, help you connect or help you be curious about patients and what's impacting their symptomology?
I think I'm pretty upfront with them. Like kids, I usually joke with my otoscope. I'm like, oh, I'm going to see if Elsa's hanging in your ear.
Somebody's in your ear, yeah.
So, that usually, they're like, what? You can see Elsa in my ear? Well, no, but we're going to look and see, right? So for kids, it's kind of that, and you can see that puts them at ease. For adults, it's not, I try to not let them get away with one-word answers. Well, you're doing okay? No, that doesn't work. Tell me more.
Tell me more,
right?
yes.
I need to
tell
hear
me
more.
about this. Tell me about that.
Yep.
So open-ended, which is another thing that only mental health practitioners learn, right? We learn over and over again how to ask those open-ended questions, whereas as a physician, you're asking these pointed questions because you're trying to go down the list of your differential diagnosis, right? So then it's this whole different way of talking to a patient.
But there's a transition point. As you're talking about something, you ask, often closed-ended, but then when you need more, asking that open-ended question often is the most fruitful.
What do you do with the time constraint? That's what I always think about with teachers. Therapists, right? You've got an hour. You've got an hour to explore and to be curious. Physicians, teachers, they're on the fly. How do you manage that and still make those connections and show your curiosity?
Well, I think that curiosity and connections are all part of it. I think things are going to come out while you're having that little bit of small talk or a little bit of discussion that are going to be relevant to the treatment. But I would say with that said is when I did more one-on-one work with people, I was never ashamed using a session to build rapport with the patient because that's going to pay off later in future sessions. I get we have that constraint sometimes, but that's often very worthwhile. Because your patient needs to trust you. And
so, for example, if a parent takes their child to the social worker and the social worker spends the hour coloring, that is just as important as you looking for Elsa in this little girl's ear. It's well, of course we're trying to figure out if she has an ear infection, but let us just get to that point. Yeah, the time constraint is hard, but it is such a powerful concept when you realize, like you said, it's just those little things. So what do you think as healthcare practitioners you can do, or what more can you do to kind of help with this mental health crisis that we're facing?
So in primary care, you're to kind of answer time constraint and what more to do, you have a limited amount of time, right? So if I were to spend an hour with each one of my patients, everybody would be miserable because they'd all be late.
They'd be waiting, yes.
So if I ever run late, of course their time is I always profusely apologize, but also let the person know, like, hey, we didn't get everything accomplished today, and that's okay because I want to see you back next week. So I want to touch base with you next week or 2 weeks. And
So
we're going to keep our
follow-up.
work. Yeah, we're going to keep our work going. We didn't accomplish everything that you wanted today, but I promise we'll get there, right? We just, so many things in one visit, and we'll keep working to get you to where you want to be.
Yeah.
And instilling hope, right? That there is going to be, at some point, they should feel better.
Yeah. And do you feel like the work that you're doing with your patients is the work you can do to help address this crisis?
Wholeheartedly.
Feel good about
Yeah.
it, yeah.
Yeah.
I think it's wonderful. Chrissy, Dr. Liston, many of our providers give me an incredibly warm handoff. So I don't just get social work consult. I get, quite a bit of text. And so I don't have to start at the beginning. So I can do, as Jake says, I can start focusing on rapport, building trust, and get to the issue without having to ask them all the same questions over again. So, and we really function as a team. We're back and forth all the time. Chrissy, I'm sorry, I can't find a therapist. What do we want to do next? And, we had an interesting case lately. We could not get behavioral health for this child because of their managed Medicare. It's not or Medicaid. It's not recognized in our community. And Chrissy had done an OT consult. And when both of us followed up with the family, it was just amazing that the OT consult gave them some more information about their child's needs. It was kind of a reframe for them because even in the waiting area, the other children were much more impaired, and it gave them just kind of a new perspective on their child. And they went home and did all this research on their parenting style.
So that's part of intervention, right? Just you giving the resource,
Right.
just you being that warm, handoff to the social worker, even if you have to wait for behavioral health,
Right.
they know that there's people who have cared,
Right.
to get them to that point.
And they've communicated to us, this is where we're at right now. We want to see if this is going to work, but we've left the door open.
And then they feel really empowered.
Can we follow up with you in a month and see if things are still progressing the way you want? Can we help you switch to a different Medicaid that's more recognized in our community for behavioral health? So,
And in terms of that handoff, I always reference my teammates by their name. I don't just say a social worker will be calling. I say Sherry's going to be calling, or our care manager Christy's going to be calling, or next time my schedule might be a little booked, but I'm going to have Christy see you and I'll see you the time after. So having it be even my medical assistant. So Sherry's going to come in and it's a different Sherry, but do your shots. So
also the predictability.
Right.
They know what to expect.
yes.
and we are a team, and
Yes.
we are communicating
Right.
with each other, and we are getting back to each other if a ball's getting dropped. So, reach out to Chrissy or reach out to me if
Right.
things change. So.
What can we do outside of our exam rooms and emergency departments to help overcome this crisis?
Well, as
Any
far
thoughts on that?
as far as social workers go and things like that, I know I've brought it up a few times here, but anything we can do to reduce stigma, I am really hoping that as time progresses, these conversations get more normalized. And I think you'd shared a minute ago, Sherry, that there was a situation where a student had said to some friends that, hey, I've had some suicidal thoughts, and they were concerned. I think the fact that we're able to have those conversations
The peer
outside,
is empowered.
absolutely. And I think the more we have those conversations, the more we're able to address things. You might not think that there's a problem until someone else says, like, hey, that's really concerning that this is happening. And I think anything we can do to normalize these conversations outside of the office are really important.
Okay. Anyone
sure.
else have any thoughts on that?
I just think Chrissy and I are trying to collaborate on more patient education for parents. And, we are the digital age. So, we don't want to be sending people to websites or watching videos that we haven't witnessed ourselves or feel are evidence-based. But, it is a time where kiddos are waiting for, even if you have a good insurance, you are waiting 4 to 6 weeks minimum.
So how can we bridge that gap?
Right.
So that's a good thing for us to remember.
Right. So we're just talking today about the American Girl book on resiliency. What things can we have immediately in our waiting rooms or our exam rooms?
So like that bridge, right? That's how we can make a difference outside. It's like make sure that there's something on that bridge for them to have or look at or feel anchored to until they are that next.
With that, I think with that, like solid safety planning, coming up with, hey, here's a plan we're going to follow. And, if between this 4-week gap, if any of these symptoms come back, here's what needs to happen.
Mm-hmm.
Yeah.
So.
Dr. Liston, what do you think? And then we're going to have a chance to ask our audience for submit some questions.
Looking outside of sort of the organized medical system, I think we have to address some of the bigger challenges, whether that's poverty, employment, other sources of chronic stress, food insecurity, as you brought up. These are things you can't just medically treat a child. You can't just psychologically treat a child. It's the whole context. And so I think we as, leaders in the community need to look at those sorts of concerns as well and get involved.
Safety, not just physical safety, but emotional safety, and not just security, but security that you have your needs met.
Yes.
Yeah, absolutely. Okay, well, let's see what our audience has to ask. Let's see. What opportunities exist to bridge the gap between physical health, so doctors, and teachers to collaborate for the success of children? It feels completely disconnected at this point. I know there needs to be more integration. Anyone have any ideas for that? Are there opportunities? What are you seeing, or what are you doing in your practice?
So I think there's a couple of things. Over the summer when I was doing my postmaster's in psych, I had the opportunity to work with community mental health, but not in the traditional sense. I did do some hours with psychiatry and med management, but I spent the majority of my time with the child crisis team. So to be able to use mental health resources to connect teachers or even provide more education to them, because I don't know how much of that, again, is in their training, right?
So give them the resource. Mm-hmm. So I'm hearing provide education to teachers on how to access those mental health supports and even the physical health supports, right?
Sure.
How to connect all the dots. And probably you would love to know how teachers feel that you could connect with them.
Sure.
Because you're probably thinking, gosh, I would love to know what's happening in the classroom,
sure.
right? Mm-hmm. Yeah.
I was mentioning earlier when my kids were in middle school and we had a pretty well-known therapist and author from Kalamazoo coming to do a presentation on bullying, and the auditorium was packed. So if there are ways we can partner with the schools to address what topics we both identify as important, to do more community education together. I'm concerned about kids that are bullied, but I'm not hearing a lot about the perpetrators, kids that are bullying. They're kids that are hurting too. They're in pain too. And, I don't often hear that topic brought up. And if we can do more education and support around that too.
Absolutely.
Yeah. Any other opportunities for that? I'm hearing we just need to connect, right? It's the connect and take that curiosity across the bridge, right? Do you mind if if I got in touch with your child's school and signing a release and just having that conversation open? Maybe the resources would then even be bigger, right? Which would be really helpful. Okay. What is our next question from our audience? We have one from our live studio audience, okay?
So this ties a little bit into the last question and also a little bit of what Dr. Liston was just mentioning about the community and the role the community plays. So when we consider a national emergency in mental health, it can sometimes sound insurmountable. We don't know what to do and how to meet the growing needs and the demand. Considering all of the systems in a community that are helping to meet those needs, juvenile justice, medical care, mental health care, school systems, what do we tell communities what's most important, and where do they start?
Do I have to repeat that? That was a long one. That was a long one, Sarah.
I think a big part of that is awareness in the community. I think, if you're not actively involved, if you don't have a child who's, involved or has a diagnosis of mental health or is involved in the criminal justice system some way or is struggling, finding resources or access to things, it's easy to just feel like those aren't problems, And I think, anything, we can do as social workers and mental health professionals to advocate that, hey, this is a real problem. And we need to make sure that everybody has fair access to, first of all, their needs, and secondly, access to services, bringing that, making people aware that this is something that needs to be addressed.
Related to that question too, we're trying to figure out, there's so many different systems in a community, and when you're trying to connect a person or a family to all of those systems, it can be really challenging to even know where to begin, right? So where do you start? And the thing that comes to my mind first is wherever they have their point of contact, I think that's where you start, right? If their first point of contact is their primary care, setting, then that's a great place to start. They feel connected to that person. Let's take those resources and then go to the next place. But the education piece of letting families know that we're speaking the same language and we have a common goal here, right? The teacher and the physician and the social worker all want your child to feel like they have the ability to learn in their classroom and have a relationship with their peers and with their adults. So again, it kind of keeps coming back to these connections and education, right? Just like awareness.
Right, and I was on the drive here, I was wondering about things like conferences where families are milling in and out of the school or school open houses. If STAR has a presence or Oaklawn has a presence, we have a booth, we have, you can just swing by and grab a brochure or talk to someone or identify who we are, that I'm the social worker, Jake, that we become.
So the interdisciplinary impact is there. The integration is so key in this. It's like the physicians have to be talking to the social workers, to the teachers, to law enforcement. It just cannot be in isolation. Wow. Okay. Well, if you didn't know about the mental health emergency, you certainly know about it now, and how important it is to have just as many adults as possible working to solve this issue. I just want to thank you all so much for agreeing to participate. Your insight and your experience is so helpful to just bring awareness and attention to this significant issue. I'd also like to thank our studio audience and all of you who attended virtually. Please join us next month for another panel discussion that will focus on culturally responsive teaching practices. Thank you so much.